Welcome to the Primary Healthcare Seminar on Mental Health, both to those of you who are present here today in the Danish residence, as well as our presenters joining online, and those of you watching through YouTube. My name is Nina Boll, and I am the health counselor at the Embassy of Denmark in Korea, and I will be moderating today. First, we will start with the welcome remarks by our ambassador, His Excellency Einar Jensen.
A warm welcome to all of you, to my residents here today. And a good morning to those of you joining from Denmark. And good afternoon to those joining from Seoul and online from Korea. It's nice to see so many people here at the seminar. A special welcome I would like to present to a Member of Parliament and Chair of National Assembly Suicide Prevention Forum, Mr. Ho Yong-yoon. Also Member of Parliament and Deputy Chair of National Assembly Suicide Prevention Forum, Mr. Yeom Sik Yong, and Member of Parliament and Chair of the Health and Senior Citizens Committee of the Danish Parliament, Ms. Jane Heitung, Executive Director of Health Insurance Review and Assessment Service here from HERA, Dr. Sun Min Kim, and President-elect of Korea Neuropsychiatric Association, also called KNPA, Dr. Kang Seop-oh. As Ambassador of Denmark to Korea, I'm happy to welcome you all to the Danish residents for our 7th seminar on primary healthcare between Korea and Denmark. Leading up to the World Mental Health Day on Sunday, and also as back in May, we are again focusing on mental health, this time especially on suicide prevention, what can be done and what are the experience from Denmark and experience from Korea. Based on the MOU in March between the Danish Minister of Health and the Korean Minister of Health and Welfare, we are working on information exchange and improving the lives of people living with mental health challenges, including the prevention of suicide. COVID-19 has resulted in more cases of mental health issues, such as depression and anxiety. This is important to handle in our healthcare systems. If treatment is insufficient, we may face devastating effects. Suicide is the most extreme example of such effects. To combat mental illness, Denmark believes in holistic approach to collaboration between hospitals and primary healthcare institutions. We believe in early intervention and prevention. We see the value of handling mental health challenges close to the patient and in the primary healthcare setting when possible. Options for treating the patients is in known settings avoid stigma and lowers the barriers to treatment for vulnerable patients. Whenever they are in a safe environment where they feel more secure, it's usually also easier to treat than and assist them. Our general practitioners in Denmark partake significantly in the treatment of mental illness, something we will touch upon today as well. Treating patients with mental health challenges in the primary healthcare sector ensures accessibility to care and optimizes the allocation of resources in our healthcare system in Denmark. It's one of the lessons we have learned. However, many things still need to be improved, and we need to find more ways to eliminate stigma related to mental illness, and we need to strengthen the accessibility to mental health care. Therefore, I'm pleased that we today have many presenters with us. We can collectively address these challenges during this afternoon. The One of Us campaign from Denmark addresses stigma and has previously been to Korea to address the National Assembly on this topic. I look forward to hearing from K-pop industry later, how experience is from there, and the way they will address suicide prevention and stigma. I'm also pleased that we will have patient perspectives from both Korea and Denmark, as well as presentations of policy initiatives from our Ministry of Health. The Korean Neuropsychiatric Association will provide substantive perspectives from professionals in the field. A very special thanks goes to Dr. Hong, who is with us here today, who has been very key in securing, the contacts and people and speakers for this seminar today. So thank you very much, and we will look forward to continuing our collaboration with you and all the people here today. I would also mention that I'm pleased that we today have the Triple One paper. I was supposed to have a copy here to show you. It's a little green publication that you will see in your folder. It has so far been in Danish and English, but today also for the first time in Korean. So you can enjoy and you can share with people all over. It tells a story of mental health in Denmark, the success and challenges and many learnings we have had over the years. And it's a special initiative from our Ministry of Health. I look very much forward to today's presentation on mental health and suicide in Korea and Denmark. I hope we will have some fruitful discussions on the value of involving the primary health sector in this regard. With our many knowledgeable speakers today, I'm sure that we can learn a lot from each other, hereby taking the collaboration on mental health between Korea and Denmark even further. These are my words, and I wish you all a wonderful and knowledgeable seminar today. I'm sure we will have a good one. Thank you. 감사합니다.
Thank you very much, Ambassador. In Korea, the National Assembly is currently having the national audit, which means that this is a very busy time for all members of parliament. Therefore, unfortunately, Mr. Yun, chair of the National Assembly Suicide Prevention Forum, has sent his apologies. We are very fortunate to have the recorded message by Member of Parliament, Mr. Young, the Deputy Chair of the National Assembly Suicide Prevention Forum.
안녕하십니까. 국회 자살 예방 포럼 부대표 정점식입니다. 오늘 대한민국과 덴마크 복지부 협력 정신건강 세미나 개최를 축하드립니다. 그리고 주제 발표를 맡아주신 양국의 전문가분들께도 감사드립니다. 코로나19 사태가 장기화되면서 전 세계가 힘든 시간을 보내고 있습니다. 대한민국은 코로나19로 인한 경기 침체, 심리적 불안, 사회적 거리두기에 따른 단절과 고립감 증가로 자살 위험도 점점 높아지고 있습니다. 지난해 자살 예방 상담 전화 상담 건수가 14,171건으로 전년 대비 53% 증가했다는 보건복지부의 발표도 있었습니다. 정신건강을 위한 올바른 정책과 활동은 자살 예방을 위해서 꼭 필요합니다. 저와 저희 국회 자살 예방 포럼 또한 그러한 문제를 인지하고 관련된 정책 세미나를 개최하여 관련 법안 개정 및 예산 지원을 위해 노력하고 있습니다. 오늘 이 자리엔 전문가, 정부기관 등 자살 예방을 위해 헌신하고 계신 많은 분들이 참석해 주셨다 전해들었습니다. 쉽지 않은 문제이지만 정신건강 정책과 효과적인 전문 서비스 연결에 대한 대안은 물론 자살 예방을 위한 많은 분들의 정책적 대안을 기대합니다. 저 또한 국회 자살 예방 포럼의 부대표로서 최선의 노력을 다하겠습니다. 참석해 주신 모든 분들께 거듭 감사드립니다. 고맙습니다.
Thank you. We highly appreciate that Mr. Jung, the Deputy Chair of the National Assembly Suicide Prevention Forum, took his time to address us today. We have Member of Parliament, Ms. Jane Heitmann, joining us online from Copenhagen. Ms. Heitmann is the Chair of the Health and Senior Citizens Committee of the Danish Parliament and the spokesperson on psychiatry for the Liberal Party of Denmark. Please, Ms. Heitmann, the floor is yours.
invitation to speak today. It is a great pleasure to participate in these knowledge sharing seminars where we can exchange experience and together rethink healthcare and create even better conditions for patients around the world. First, I would like to thank the member of the National Assembly and chair of the National Assembly Suicide Prevention Forum, Mr. Ho Young-Yun, as well as member of the National Assembly and deputy chair of the National Assembly Suicide Prevention Forum, Mr. Yeom Sing Young, for their remarks. Your positive words about Denmark are greatly appreciated. I'm also extending my appreciation to the President of HIRA, Dr. Sun Min Kim, and President-elect of Korean Neuropsychiatric Association, Dr. Kang Seok-un, as well as Ambassador of Denmark to Korea, His Excellency Ejner Jensen. I would like to congratulate all Koreans present for your country's impressive handling of the COVID-19 pandemic. You have been well prepared and you have been able to strike a balance of keeping the infections under control while still keeping large part of the society open. You have served as an example and inspiration to many countries. Furthermore, we are pleased with the close collaboration that our two countries have had since 2013 regarding healthcare. Korea has an impressive pace when it comes to improving healthcare. And this brings many opportunities for us to learn from Korea, as well as to showcase our own experience and Danish solutions to the challenges that we share. The Danish royal visit to Korea in 2019 to celebrate 60 years of diplomatic ties further underlined close collaboration between our countries, which we will continue to build on in the future. Just before the world closed down due to COVID-19, I had the pleasure of welcoming a delegation from, among others, the National Assembly of Korea to the Danish Parliament, where we had an interesting talk about mental health and suicide prevention. Part of the delegation was Professor Pike, whom I'm pleased to see is also present today. Suicide prevention is a subject of high concern in Korea and something that we in Denmark have worked actively with for many years. I know that the great collaboration between Korea and Denmark on this important subject is still ongoing and brings value to both countries. The New Deal initiative in Korea, and especially activities concerning smart hospitals, is very exciting and something that we will follow with huge interest. In Denmark, we have quite a lot of experience with super hospitals. One being the award-winning Slagelse Psychiatric Hospital that is globally known for its healing architecture, which includes the world's most advanced LED lighting system and healing decoration. We look forward to share our experiences with Korea, as well as to be inspired by your approach and your advanced technological solutions. As most other countries in the world, we are challenged by the increasing number of patients with chronic diseases. Healthcare systems around the world are stretched to the limit, and we need to think out of the box and take a different approach to solve this challenge. In Denmark, we see strong public-private collaborations as one of the solutions to this. We have a well-functioning public healthcare system in Denmark, but there is still a lot to do, and we can always improve. We see benefit in inviting private players to bring in innovative solutions that can take some of the pressure off the healthcare system. These solutions range from remote handling of blood sampling and tests to diagnostic apps and personal support through digital solutions. The Center of Telepsychiatry is a research and development center within the mental health services that promotes the use of telepsychiatry and e-mental health to improve the quality and accessibility of care for people with mental health problems. These strategic partnerships have fostered more health as well as more research and resulted in integrated health solutions that benefit both the patients and the society. Health and well-being are one of the key growth, and investing upfront in better health is an investment that will pay off in the long perspective. A common feature for all these new patient solutions is that they have been developed with patient-centric approach. In Denmark, we have a long tradition of putting the patient in the center. In Denmark, we find that it is important to have a strong primary health care system. This goes for many areas, not least the area of mental health. We need to ensure that patients in need have access to treatment, for example, for depressions, in the primary health setting. Patients with depression need to have easily accessible treatment options in known settings. This year, World Mental Health Day theme is about mental health in an unequal world. Inequality fosters issues in mental health, which is why we look forward to discussing ways of promoting equal and fair access to treatment. I hope that you will enjoy the seminar today. Thank you for your attention.
Thank you very much, Ms. Heitmann, for your inspiring remarks. We will now hear the keynote speech by Dr. Sun Min Kim. She is the Executive Director of the Korea Health Insurance Review and Assessment Service and is joining us online from Wonju. Please, Dr. Kim.
Good afternoon and good morning. I am Executive Director of HERA, Sun Min Kim. Before I begin my presentation, I wish to express my deep appreciation to His Excellency Einar Jensen, the Ambassador of Denmark to Korea, for organizing today's meeting. I am more than pleased to join this valuable meeting as a keynote speaker. Actually, from the Korean War in 1950, Denmark has provided a lot of medical support and assistance to Korean society. Thanks to such assistance, Korea has successfully managed to make the transition from aid recipient country to a donor country. In that process, Korea could accumulate a rich institutional memory and became a country with valuable knowledge to share. Cooperation in health sector between Korea and Denmark is underway in various ways. Today's seminar on primary care and mental health is also an extension of such efforts. It is my sincere hope that today's session be productive for both countries. I'd like to touch upon the general characteristics of mental disorder in Korea. As this OECD statistics shows, suicide rates per 100,000 population was 23% in Korea, which means that we are not doing so well. Similar trend is observed in suicide within 1 year after discharge among diagnosed with a mental disorder. Hospital length of stay is one of the important performance indicators of mental disorder. In comparison to the other OECD member countries, Korea's length of stay is considerably high among inpatients suffering from schizophrenia, mental and behavioral disorder. I would like to draw attention that the majority of psychiatric disorder in patients tends to stay hospitalized for a long time in comparison to the other OECD member countries. This trend is more prominent among medical aid beneficiaries than the national health insurance subscribers. To understand the reason, it helps to track the hospital's beds of the psychiatric and the number of psychiatrists per 1,000 population. The hospital beds of psychiatric care in Korea is 1.23 per 1,000 population. This is much higher than WHO recommendation, which is 1 per 1,000 population. On the other hand, the number of total psychiatrists per 1,000 population falls far short than in the other countries. We can easily induce that the mental health sector in Korea operates centering around the caring psychiatric inpatient within the hospital. Nevertheless, we are failing to provide sufficient care to the psychiatric patient within the hospital due to the shortage of the human resources in the psychiatric hospital. Let us briefly turn to the single united national health insurance system in Korea, which covers around 50 million population. Socially and economically undeserved class of about 1.5 million beneficiaries of the medical aid. Patients with mental disorder and their family face a very high risk of falling to a low-income class due to the burdens of psychiatric condition. More often than not, they tumble down from the national health insurance subscribers to the medical aid beneficiaries, which are relatively poor. This diagram could be seen as a proof of such phenomenon. Around half of the psychiatric inpatients are beneficiaries of the medical aid program. Next, please. That is why there is a relatively low level of attention regarding mental disorder in the National Health Insurance Scheme. As you are aware, unlike other diseases, mental disorder requires a wide range of social welfare services from healthcare to housing, vocational rehabilitation, and employment support, and etc. In Korea, health service development was mainly driven by the central government and its national health insurance program. Also, healthcare service providers are dominated by the private sector in terms of number. To meet the needs of community-based mental disorder care, current system has some limitations and falls short. In addition, to provide community-based mental health services through public health care providers such as local health centers and public health centers, there are many limitations in terms of organization, capacity, and budget. Another issue is the social stigma on mental health and mental condition. The strong stigmatization in Korea is a big hurdle for patients when they seek the medical intervention. All these factors make the situation more difficult for those who need mental health services. Despite these difficulties, the Ministry of Health and Welfare, HERA, and National Health Insurance Service have continuously tried various approaches to improve psychiatric care system. Under the Mental Health and Welfare Act, criteria for inpatient wards have been strengthened to improve quality of hospital beds to relieve overcrowding issue at psychiatric hospital wards. By maintaining appropriate number of beds, we are attempting a switch to community-based services from the hospital-centered services. For medical aid, outpatient fee schedule has been revised to encourage the use of outpatient services. To improve service underuse, due to low level of fee schedule, essential services are subsidized so that the treatment effect is improved. Length of stay is shortened and the readmission rate is reduced. There are many pilot programs underway to shift the paradigm of the psychiatric services from inpatient service to the community-based service. Community-based psychiatric care system has not been fully developed yet. We began pilot programs for case management and daytime ward management last year in order to facilitate the settling down in the community and reduction of readmission. We mean the pilot programs with introducing within the health insurance system. We also launched a pilot program in the National Health Insurance to decrease suicide this year. The main content of the program is to provide suicide attempters who are admitted to emergency rooms in the general hospitals with case management services and comprehensive mental health and welfare services. We are also planning another pilot programs connecting local clinics and the psychiatric institutions. In this program, we will screen the patients who visit primary care facilities to identify mental health risk group among all visiting patients so that early intervention is possible. Today, I've shared several efforts and attempts Korea has in a very briefly manner, but there is a long way to go. However, I am confident that we can move towards a brighter future as we strive to keep strengthening mental health services based on the collaboration of both countries. My understanding is that today's seminar will cover diverse issues of Korea's mental health system. I wish both sides a productive and fruitful session for better mental health care system. Thank you very much for attention.
Thank you very much for your wishes, Dr. Kim, and also for your very informative remarks. We are pleased to have Dr. Oh, President-elect of Korean Neuropsychiatric Association and Professor of the Department of Mental Health at Kangbuk Samsung Hospital, here with us in the residence. I will pass the floor to Dr. Oh for his keynote speech.
Thank you. Good day, everybody. Good morning, Denmark, and good afternoon, Korea. It is my great honor to have this wonderful meeting. As you know, mental health issues is one of the most important social and national problems over the world. Especially, it's been so long time we have been experiencing comorbid pandemic situations. So many mental experts, they are worrying about the rapidly increasing mental problems like depression and suicide. As you know, unfortunately, suicide rate in Korea is already the highest among OECD countries over than 1 decade. for recent several years, many experts tried to decrease suicide rate in Korea, and also Korean government started many mental health promotion projects. However, we still have a higher suicide rate in the world. In the past, as I remember that the Scandinavian countries, including Denmark, had a higher suicide rate over the world. However, now the suicide rate of Denmark has been below average over the world. So I believe that this meeting can give us the advanced knowledge from Denmark, and also we can share our recent Korean experiences. I hope that with this meeting, we can exchange our knowledge, and also we can expand our information. Finally, I appreciate Denmark Ambassador Mr. Einar Jensen and Councillor Dr. Boel and Health Officer Ms. Park for your organizing this meaningful meeting. I also appreciate all speakers and participants. Thank you very much.
Thank you very much, Dr. Oh, for your wonderful remarks. We will now turn to today's presentations. Our first presentation is from the head of the division at the Danish Ministry of Health, Mr. Carlo Andersen. He will be presenting and speaking on the Danish government's policies on mental health. Please, Dr. Andersen.
Can you hear me?
Yes, we can.
Thank you very much. Can you also see the presentation on the screen?
Yes, we can. It looks perfect.
Thank you very much. Good morning from Copenhagen and good afternoon to everyone in Korea. Very nice to see you all again. Good to see familiar faces from earlier webinars and Korean visits in Copenhagen. On behalf of the Danish Ministry of Health, I would like to thank you for giving me the opportunity to make this short presentation on the Danish government policies on mental health on psychiatric care. Unfortunately, I only have 10 minutes to do my presentation, so obviously this will be very, very brief. But first, let me allow just to use a few seconds on some advertising, because the Danish Ministry of Health and Healthcare Denmark has produced a paper on mental health very recently with a foreword from the Minister of Health, and it's been translated into Korean and also handed out to you today, as I'm been aware. So that's very, very positive. The paper covers the Danish approach and includes examples from civil society, government initiatives, as well as a lot of initiatives from the psychiatric hospitals. It covers how Denmark successfully has lowered the suicide rates and some of the initiatives that led to this. Furthermore, digital psychiatry initiatives are also described, along to see how we do the early intervention and how that is making a difference. So hopefully you will find this booklet fruitful for your further work. Very briefly on the organization of mental health care in Denmark. We have the national level, the regional level, and the municipality level. On the national level, which is the Ministry of Health, we have the overall responsibility and the legal framework for the psychiatric care in general, while our distinguished colleagues in the Ministry of Social Affairs and Senior Citizens are responsible for social services. That means assisted living, treatment of substance abuse, and so on. On the regional level, we have 5 regions in Denmark that are responsible for the operations of the psychiatric hospitals. That means that the hospitals offer both inpatient and outpatient care. And also the regions are responsible for having agreements with the general practitioners, the GPs, and also psychologists and other healthcare professionals that work in their own businesses. The local GP acts as a gatekeeper that can treat patients or refer patients to psychiatric hospitals or to a practicing psychologist with partly reimbursed costs. The 98 municipalities in Denmark are responsible for a wide range of local services, including social psychiatry, housing facilities, and so on. They're also responsible for local preventive measures and rehabilitation after the patients have been discharged from the hospitals. Just to give you a few statistics of the development of the patient inflow, in the period from 2009 to 2018, there has been an increase in patients in the regional psychiatry of 31%. If you take the numbers and put them into age categories, you will see that we have experienced an increase of 27% in adult patients and an increase in children and young patients, adolescents, by almost 50%. You have to know that Denmark is a bit smaller than Korea, and we're just about 6 million people here, and approximately 170,000 people are unique patients that have received treatment within the regional psychiatry in 2018. In the general population, 12.1% of the general populations have received treatment with medicine for their mental illnesses. I would also like to address suicide prevention and the work we're doing about that in Denmark, because I know that suicide prevention is a very important topic for you in Korea. And just to give you an example of the development is, you can see here that from the period of 1980 and up until the millennium, we've seen a quite remarkably decline in the suicide rate, but unfortunately, since the millennium, the rate has been more or less stable, and that means that about 600 people a year commit suicide in Denmark. I'm pretty sure that we will also address this topic in the upcoming 10-year plan for the psychiatry. The decline in suicides from 1980 to up until the millennium was achieved by a number of initiatives. Primarily restricting access to known suicide methods. That means reducing in package sizing in painkillers and analgesics, and removal of carbon monoxide in household gas. We also know that gender is a clear risk factor. Males are much more likely to die from suicide than women, and we can also track suicide attempts, although underreporting and people not seeking help is a big issue here. It is estimated that somewhere between 6,000 and 12,000 people come into contact with hospitals every year after they have tried to commit suicide. The work with suicide preventions are also important to mention here. The suicide prevention centers provide important work every day, and they are categorized into the 5 regions. And are permanently funded with 12 million Danish kroner, that is approximately 2 million American dollars. And they provide treatment for patients that attempt suicide, counseling, supervision, and education of professionals. And the professionals, of course, are those that come into contact with persons that are at risk of suicide. Besides the suicide prevention centers, we also have a national partnership on suicide prevention that is hosted by the National Health Authority. And the Ministry of Health are also a member of this partnership. It provides the framework for knowledge sharing, inputs for national authorities, and consensus building. It also distributes funds for activities aimed at suicide prevention. That means research, pilot projects, conferences, and so on. The regional suicide prevention centers, the research institutions, civil society organizations, and government agencies are in total the members of the national partnership. Also, and very happily, the national partnership was extended last year with further funds. So we have funding for this partnership up until 2024. Also worth mentioning are Livslinjen. It's a national-wide counseling initiative for suicidal people and their relatives. you can contact the Lifeline, Livslinjen, via phone or over the internet or via a chat function, and is permanently financed by the Finance Act in Denmark. Also worth mentioning is the fact that the media in Denmark has an agreement to address the Lifeline, this initiative, every time that they write about suicide or suicide attempts. Lastly, I would like to address the challenges that we need to meet in the current 10-year plan that we're working on. As I've already mentioned, we see an increasing number of patients in the regional psychiatry, and this is further a problem because we have huge recruitment difficulties among almost every healthcare professional group in our psychiatry, from doctors to nurses to every other kind of healthcare professional. We've seen an increase in children and young people with mental health issues. This has probably been worsened by the pandemic and the restrictions that have followed with this. In general, we see a higher mortality and morbidity rate among psychiatric patients, a huge inequality that the Danish government wants to address also in this 10-year plan. And in general, we need a more near and coherent care pathways. So this is also a very important topic for the 10-year plan. And lastly, we need to develop more knowledge and research about psychiatric care and psychiatry in general, also to address the recruitment difficulties. Luckily, we are not starting from scratch in terms of building up a new 10-year plan. There has been a political focus on psychiatry and mental health care during the past decade. Of course, this is in Danish, so you will bear with me, but the Orange Paper was the first huge initiative from the Danish government in 2013-2014, which included a very elaborate work that led to a plan that called Equality. This is the second one you will see with the people walking on the beach. This led to a number of initiatives, but unfortunately not the huge development of psychiatric care in Denmark that we wished at that time. Later on in 2018, the Liberal government in Denmark at that time presented a 10-year, not a 10-year plan, but a plan towards 2025 for the mental health care. And some of this has been was actually made into the healthcare sector, but unfortunately there was an election, and some of this means that it didn't get the funding that it needed. So now we have to do an elaborate 10-year plan, and hopefully we will experience a political focus and an agreement with all parties in Parliament. That means that we have the 10-year plan ahead of us that will make the bigger difference that we haven't experienced earlier on. So just to thank you for your attention, and I hope that you will experience a very fruitful webinar, just as the ones we've had earlier on. I hope that also the booklet that I talked about earlier will be fruitful for you, and as I said, is translated into Korean. So in general, thank you very much for your attention, and I hope that you will have a very fruitful day. Thank you.
Thank you very much, Mr. Andersen, for this very informative presentation. We will now hear from the Korean side. Dr. Hwang is the president of Korea Foundation for Suicide Prevention and is representing the Korean Ministry of Health and Welfare. Dr. Hwang will be presenting the Korean government policies on mental health. Please, Dr. Hwang.
Thank you for your introduction, and it's my great pleasure to present to you the mental health and the suicide prevention policy of Korea, commemorating the World Mental Health Day. Would you please give me the present? Okay. So this slide shows you the recent trend of suicide in Korea. Compared with the 2019, we can see the decreasing number of suicide in 2020 and 2021. So the Economist journal from UK mentioned that the suicide rate of many countries are decreasing during the COVID-19 pandemic because of the financial support and maybe the strong network by each country's government. And it's the same in Korea. And then this slide shows you the status of suicide in 2019, and you can see the difference between the gender. So in case of men, you can see the increasing number of suicide by age. But in case of women, you can see the two peaks. The first peak is on 30s, and then the second peak will be 70s and 80s. And then if we look into the cause of suicide, you can see the very different cause of suicide among men. And then the young men because of the mental illness, and then middle-aged men because of the economic issues, and then the elderly man is because of the functional disability because of the physical disease. But in case of the women, all age complaining about the mental health issues. So this data is from the National Health Insurance that the suicide completers, among the suicide completers, about half of them are, they were suffering from depression. And then 1/3 of them were complaining about the sleep disorder and the anxiety disorder. So they visited the psychiatric clinics and then received the prescription from a psychiatrist. So these kinds of mental health problems, we should think about how can we improve the accessibility to the psychiatric clinic to treat the depression, sleep disorder, or other mental health problems. And this slide shows you the governance of the mental health and suicide prevention of Korea. So in the Ministry of Health and Welfare, there is the Bureau of Mental Health Policy. And under the Bureau of Mental Health Policy, there are three departments. So two departments go to the mental health area, and then the Department of Suicide Prevention Policy is for the suicide prevention. So my foundation, the Korea Foundation for Suicide Prevention, is working with this department. So if we come to the Department of Mental Health Policy, under the Bureau of Mental Health Policy, there is the National Center for Mental Health and 4 national mental health hospitals to taking care of the inpatient and outpatient. And if you go to the province or metropolitan city, you can find the Metropolitan Mental Health Center and also the Metropolitan Suicide Prevention Center. But the number is very different. So you can see the very small number of Metropolitan Suicide Prevention Center. And also if you come to the local city, you can find many community mental health centers in the local city, and also 50 addiction prevention center. But in the local city, there are lack of suicide prevention centers. So government would like to set up more suicide prevention center in the local city in the future. So this is the typical case management system of the community mental health center in Korea. So usually the case management system is for the severely mentally ill patients. So traditionally, the community mental health center is managing the schizophrenic patient or severely depressed or bipolar patient. But right now, in the era of the COVID-19, there are many crisis cases by the suicide attempters. So right now, the local the community mental health center staff is taking care of the suicidal attempters in the community. So this slide shows you the action plan in the year of 2018 after the establishment of the suicide prevention department. So the government would like to build the evidence-based suicide prevention the strategy. So the national surveillance system of suicide trend is right now is very important. And then according to the stage of suicide, there are several different strategies. So in case of the identify the people with the suicide ideation, we should think about the depression screening, usually by the National Health Insurance the service. And then there are different the approach for the people with the suicide planning or the suicide attempt. And then we should develop some suicide prevention program by the age group. I will comment this later. For the evidence-based approach and then the development of the strategy in the local level, the data is very important. So right now, we are collecting the data from the Statistics Korea, the National Police Agency, National Medical Center, and Ministry of Education. So we are making the database with this data, and then provide this data to the local the cities to establish the very tailored suicide prevention policy by the local cities or the province. And also, this data is very important to establish the policy in the community mental health center. As I told you, the local mental health services is very important to reduce the suicidal risk. So in the local level, the community mental health center staff provide the suicide prevention services to the local people. And also, as the director of HERA mentioned, the hotline, the 1393, the phone number, is very important for the counseling services who are in the very crisis situation. And also, for the depressed patient, the accessibility for the mental health services or psychiatric outpatient services are very important. So if the patient comes to the local community mental health center and then the staff thought this patient needs a medication, then the staff can refer the patient to the local psychiatric clinic. And also for the suicidal attempters, the emergency service is very important. So for many years ago, the Central Suicide Prevention Center would like to establish the network with the emergency room. And right now, more than 76 university hospitals or general hospital emergency room established the case management program for the suicidal attempters. And then we would like to expand that kind of service to other university hospital or general hospital. As I mentioned, the intervention by the AG is very important. And then also we should develop a very different strategy for the suicide prevention for the seniors or the military personnel. Recently, we can witness many suicide in the army. So we need more special approach for this military personnel. And also, we can see many college students commit suicide because of stress of the studies or their unclear future to getting a job after graduation from the university. So in the case, we must provide some special intervention or some support for the population. So for to save the previous precious life and also to create the culture of respecting life, the Korean Foundation for Suicide Prevention was established this April. So the mission of our foundation is to realize the safe society through creation of the social movement for suicide prevention. So we would like to invite every Korean to be a gatekeeper. And our vision is to establish the evidence-based policy development and service implementation in the local city. So as I mentioned, the educational program for the gatekeeper is very important. So we already trained more than 3 million Korean people as the gatekeeper, and we need more. So I would like to invite all of you for the online education program for the gatekeeper in the future. And also suicide awareness raising project is especially for the college student or young people. So we are recruiting the supporters for our foundation to be involved in the social awareness campaign because there are many stigmas also to the suicide, just like a mental health issue. And then I think the suicidal attempters and then the believed families are high-risk group. So we should develop some psychological counseling or financial support for the patient, suicidal attempters' families. So fortunately, the Korean the Life Insurance Association donates the big money to our foundation. So we are supporting the treatment of the family members right now. And also the suicide post-prevention program is another one. And then the friends or colleagues of suicide completers are also suffering from the PTSD or very stressful situation. So if you want that post-prevention service, please call this hotline. So it's my caricature, and then my nickname is life-saving psychiatrist to communicate with the general population. And as you know, the next March, we will elect the new president of Korea, and there are many candidates. So it's our duty to prioritize the suicide prevention issue as a political agenda. So we are collaborating with many journalists, just like Mr. Kim, to make the political the agendas for the prevention of suicide. So please support my foundation to do more work in the future. Thank you.
Thank you very much, Dr. Huang, for your rich presentation. Our next presenter is Dr. Peck, who is the Legal Affairs Director of the Korean Neuropsychiatric Association and a professor at the Department of Psychiatry at Kyung-hee University College of Medicine. Dr. Peck will be delivering a presentation on Korea's mental health system.
Thank you. I'm Jung Baek. This moment, I really wanted to go Denmark, but we have to postpone after COVID pandemic. But fortunately, 2 years ago, Denmark embassy invited us to Denmark, so we had chance to see the primary healthcare system and mental health system. So today's event is more meaningful to us. I'm going to talk about Korean mental health system today. To meet the 10-minute presentation time, I'll walk you through the flow and concept. It is also a story about our father, mother, and children. This is Gyeonggi University Hospital where I work. I have mainly worked on depression and suicide prevention. I'm currently the legal director of Korean Neuropsychiatric Association. Korea achieved industrialization and democratization in a shorter time than any other country in the world. When I was young, my father always woke up at 5 o'clock to study foreign language and returned to after 12 o'clock. So it is so difficult to see my father's face. My father had 7 brothers and sisters, and they share everything in work and life. But for me, I have only one brother. During this period, severe mental illness was a family problem. Both the decision to be hospitalized and the cost burden were up to the family. When our country, when other countries were deinstitutionalizing, the Mental Health Act of Korea was enacted and resulted in hospitalization since 1995. On the one hand, it was considerable progress. But nowadays, the side effects of the long-term hospitalization are problems that need to be solved at this point. Those here are well aware, but Korea's suicide rate is the #1 among OECD countries. But why is the suicide rate higher in the era of $30,000 income than when per capita income was only $100? Over past 20 years, you can see the respondents ratio that family members were responsible for supporting their family, their parents, when they were sick, went down from 90% to 30%. Now, it is challenging to keep dementia patients and severe mental ill people and prevent suicide only with the power of family. It is almost impossible for family members to take care of a parent with dementia, severe mental ill, or suicidal patient. A very big change. On the other hand, Korea is the lowest among OECD countries in Social Support Network Index. I think it is connected to highly suicide rate. While Denmark, you can see that Denmark is 5th. Do you know Squid Game? Yeah. Oh, nice. Squid Game is a popular airing on Netflix these days. The main character live alone only with his mother. Yeah. Since I mentioned my father had 7 brothers and sisters. I have only one younger brother. Since a few years ago, the word Hell Joseon, Hell Korea, is popular in Korean society. Why? Participants in the Squid Game get out of the death game by voting, but and go out to reality and come back to participate in game, thinking the reality is more hell. Why? If there are several consecutive life crises, anyone has become can feel suffering and fall into suicide crisis in Korea now. Income has increased from $100 and $30,000, but our people's mental health is in crisis. To solve mental health problem of the new era, we have investigated mental health system in various countries. In particular, our visit to Denmark was very beneficial, and we met Ms. Heitmann in Denmark Parliament. Denmark had a high suicide rate like us in the late 1980s, but nowadays decreased to half as the social network expanded and access to mental health care improved. It was also confirmed many investments were being made in community mental health service in many countries. Change have already begun in Korea. Dr. Hwang mentioned the Ministry of Health and Welfare has created the Mental Health Blue, and the mental health budget has higher rate of increase than another field. National level plans have also been announced. Above all, the revision of related law is speeding up with creating the National Assembly Suicide Prevention Forum. Thank you again for joining us at the Danish Embassy from first international seminar of National Assembly Suicide Prevention Forum. You can see many Denmark members. And today, a special guest, peer specialist of Mental Health Korea, who participated here today, also talk of mental health at the National Assembly. In addition, the situation COVID-19 come. COVID-19 has very negative impact on mental health, such as depression, anxiety, anger. This is a slide of Ministry of Foreign Affairs of South Korea to explain Korea's response to COVID-19, known 3T model. 3T model prevent the spread of COVID-19 by detecting it early via overwhelming a number of PCR tests and tracking it by quarantine officials, and to link it to special care unit. This shows how much Koreans work hard. Change is fast and dynamic. After all, I think the problem is how we prioritize. I think it's time for Korea to invest in the issue of people's happiness and mental health instead of rapid development. I've been talking about this issue lately. Let's deal with mental health problem as if we were actively responded to COVID-19. Let's invest in our heart and our mind. Just as Korea achieved rapid industrialization and democratization, we hope community mental health service will also proliferate and grow. Anyone can fall into a crisis of life if only person next to them listen to their stories and support them, like them, we can find hope. Now is the time for our society to create a safety net to replace large family system and deal with mental health at the national level. In the process, I believe cooperation with Denmark will inspire us. Thank you for your attention.
Thank you very much, Dr. Peck, for your very rich presentation. Thank you very much to all of our first three presenters. We will now turn to our discussion. As President-elect O mentioned to me, the discussion is the most important part. For all of us here present here in the residence, please use the mics that are on the tables when you speak. Before I open the floor and take any questions there may be, I would like to direct two questions to our presenters who are present here in the residence. First, for Dr. Huang, I would like to ask you, how does early intervention make a difference for tackling mental health challenges and for preventing suicide? Would you share a few ideas and reflections on that, please?
Yes. I think the early intervention is very important for the mental health care, and also if the people has some suicide idea or suicide planning. So in Korea, in the local community mental health centers are now developing some early identification and then early intervention for psychiatric disorders such as psychosis or depression. So if we can provide some intervention after the early recognize of the depression, I think we can prevent the progress of depression to the very serious refractory depressed state that is related to the suicidal attempt. As I presented, among the suicide completers, almost 50, they suffered from depression. So if we early identify their mental health problem, including the depression, we can refer the patient to the psychiatrist. So as the director of HERA mentioned, there are pilot projects for the medical insurance investment for the referral of depressed patients from the local clinic, such as a pediatric clinic or OBGY clinic, if the doctors found some depression among the child or the postpartum depression, the patient in the OBGY clinic, then the doctors can refer the patient to the local psychiatric clinic. In the case, the HERA will reimburse the fee for the referral of the clinical doctors. So that kinds of early recognize of any patient in the community and the referral to the local psychiatric clinic, that will be a good solution for the intervention by the psychiatrist, I think.
Thank you very much, Dr. Huang, for sharing those reflections. Dr. Peck, you have been in Denmark, and you're very knowledgeable about both the Danish and the Korean healthcare system, as well as the primary healthcare setting and the secondary healthcare setting. I wanted to ask your opinion on the primary healthcare setting and what sort of how the primary healthcare setting can benefit and help people with mental health challenges and also help prevent suicide.
Very good question. 2 years ago, I visited primary healthcare clinic in Denmark and Bellagio psychiatric hospital. So we could see it is very effective and integrated system. Denmark has internet-based medical record system. GP and specialist can see same chart, and GP can ask the specialist by email or chatting, and so I surprised nearly above half people of Denmark donate their genetic information to national government. So Denmark has very good cooperation system between primary clinic and specialty clinic, and the charge of regional psychiatric center told me their concern and goal is to decrease waiting time for seeing psychiatrist. Average 6 weeks. They want to decrease to 4 weeks. I asked them how many patient psychiatrist see one day. He told me 4 patients a day. I couldn't say how many patients I see in Korea. So there are some gap. In Korea, above 90% of doctors completed resident training and get certification of special board. So it was helpful to make a treatment-centered approach. But nowadays, our government have want to make a primary care system, but I think by the cultural and systemic difference will make with some time. Yeah. And one more, and we found very good emergency system in Denmark. Denmark psychiatrists provide 24-hour specialist call service for all peoples and police and 911. So I think it will be very helpful for Korea. Yeah.
Thank you very much, Dr. Peck, and I think that President-elect might want to add a bit to that.
Yes. Yeah, I totally agree with your answers and questions. The early intervention is very important. So I remember that in Japan, in the local clinic for especially elderly people, they checked one-page checklist for the all patients to visit local clinic. And for example, how was your sleep? How was your appetite? How was your mood? 5 or 6 items. But after checking the page, even though they checked just one item, that time every doctors they have to report to the psychiatrist or other specialist. So it means the early intervention is very important. It is very successful suicide prevention strategies in Japan. So it is important. However, I was very impressed with Dr. Peck's presentation, like COVID prevention 3T, test, trace, and treat. Among them, the test is very important. However, I think the proper test, appropriate test, the proper evaluation is very important. So we have to divide it is this patient could be hospitalized or can provide medication. So we need early intervention, and proper evaluation is so important, I think.
Thank you very much, President-elect Oh. And I would now like to open the floors for any further comments or questions. Yes, please, Director Lee.
Yeah, I have a question to Mr. Andersen in Denmark. Is he's here or?
I'm not sure he's still here. Could we please?
Oh, I'm
check?
sorry. Yeah, question is very simple. Your suicide rate is high, but it's continuously in the slowdown. So I wanna, what is your strategy or cornerstone? Maybe. So if you have that kind of strategy, please share your experience to Korea.
We will definitely make sure to convey that question to Director Andersen. Thank you very much.
Don't you know that, Nina?
I don't want to comment too much on the health ministries in their place, but we will convey the message to them and provide you with the answer. Any further comments or questions?
Last year, I met Dr. Noordendorp, who is the director of National Institute for Suicide Prevention. She told me the lesser mean restriction was very helpful, especially parricide and drug injection. And the other state strategy was to expand social network, social safety network, and third is to national levels anti-stigma movement to increase mental health service usage. And last is in Denmark area, winter depression is so high and sometimes lead to suicide. So they made a very awareness campaign for winter depression. Yeah.
Can I have one more question?
Yes, please.
One more question to the Korean expert. Actually, I think that in the suicide rate is a pressure. I think so. Maybe in some days, sometimes we slow down. So, what kind of effort needs to rapidly drop down this suicide rate? How do you think about it, Dr. Hwang?
You are very optimist, I think, but many specialists are worrying about the delayed suicide after the COVID-19, just like IMF. After IMF crisis, we witnessed the suicide increasing after 2 or 3 years later. So, and then just like your question, if we would like to reduce our suicide rate in Korea, many sociologists point out that the suicide is not just an individual the event or a tragic story, but the suicide rate of one country reflects the integration of that society or some status of welfare support for the vulnerable or poor people. So if we want to reduce the suicide rate, we should think about the early intervention for depressed patients. But as a whole society approach, we should think about the support for the vulnerable people, and then increase the integration of our society.
So we should in the closely observation in the few years
Yes.
after COVID.
Yes.
In my opinion, for 20 years, old age people's suicide increased Korea's suicide rate for 20 years. But nowadays, as you know, suicide rate is number one at old age people. Number of suicide is number one and 40 and 50. But nowadays, baby boomer generation will start to retire from this day. If the suicide rate is the same, the number of aging people will increase. Suicide will increase. If we don't do anything, suicide will increase naturally by population. Yes. But and another problem is young age people. Last year, Japan, young age people and women's suicide rate increased by COVID-19 pandemic. Our data show 20 and teenager suicide rate increased last year. So I think if we don't do anything, our suicide rate will increase.
Thank you very much, Dr. Peck, and also for putting that into relation to the changing demographics. Perhaps our ambassador, Einar Jensen, has a comment?
Yes, a very interesting discussion here. I think what you are saying, Mr. Hong, is that, once you have a more elaborated welfare system, maybe in the case of Denmark, we have, free education, free healthcare, pension schemes, elderly care, child care, and even if you fall unemployed, you have sort of kind of safety net under them. I think that might have helped us over the years to gain lower levels, because when we look, I think it was in the newspapers day before yesterday or whatever, that over 40 years, it's halved or 1/3 of what it used to be, our suicide rates. So maybe the welfare system is helpful, maybe, I think so. But I think also it seems to me, I'm no expert, but in the old days we had more difficult antidepressant, medicine. Now today it's a newer generation of antidepressant. And honestly, we have saw some of the figures from Denmark. Quite a lot of Danes are still being treated and helped with antidepressants. So I think it's maybe it's access to antidepressants. Maybe it's the possibility from even your family doctor to get the antidepressants, and in that case, early intervention. I think you mentioned, or you also mentioned early intervention. And so I would like to ask you the question to you, how is it here, is it, should it remain only with psychiatrists forever to provide the antidepressants, or do you see any openings with a new, I think, again, I'm no expert, but I'm just told that new antidepressants are different from the old ones that were quite more dangerous and had to be looked after in a different way. So that's one question for me. So, yeah.
All depression treatment guidelines recommend the physician, especially competent to depression treatment, prescribe antidepressants because depression treatment need antidepressant treatment and psychotherapy. I think, yeah. So in Denmark, many physicians get training to provide counseling and psychotherapy. I think it's a very good system. But in Korea, until now, all department of specialists see their specialty area. So they do not provide psychotherapy. So we need to change this trend and make primary clinic for people. Yeah. So it takes some time to change.
I would like to add some comment about suicide prevention and the treatment of depression. When you treat the depressed patient, the part of medication is just, I believe, 60% or 70%. With the rest part of treatment is psychotherapy and the environmental change and the family support and social support. And with that, the depressed patient can change their mind with the suicide ideation to the survival ideation. The other thing is SSRI is very good medication for depressed patients. However, we have to remember that in the SSRI black box, there is a suicide caution. It means in the beginning of SSRI treatment, when we do not use properly, that can elaborate the suicide ideation in the beginning with SSRI. So we have to be very cautious. And also, we have to treat the side effect. So it is sometimes very dangerous. Yeah. So in my case, in the early treatment of SSRI in Korea, we are very cautious about the dosage decide. It was difficult for us. So we have to very cautious about the treatment. The other thing is for reducing suicide in Korea, we change our consensus about suicide in general. You know, in Japan and Korea, ordinary people, they are very generous for suicide. Suicide can be rationalized. So I mean, if I have some disaster or some disabled, I can die. So many people, you can die. That's not, yeah. Even if I have some disaster and disabled, I have to survive and I have to live with our family. Yeah, so our program, suicide prevention program, is about the meaning of living, and we have to change about the consensus about suicide. So it can change our suicide rate, and it can reduce the rate, I believe.
Yes, please.
I checked out in the HERA guideline for SSRI. So we needed some correction. After family physician or in the neurologist can describe in the SSRI for 90 days. And then it couldn't know. And then they check, they refer their patient to Dr. Peck. And then I get back to him and prescribe another 90 days. So that is the very important thing. Is so some neurologists and the family medicine think that I'm a doctor. Mm-hmm. I can prescribe anytime. But in the psychiatry system, okay, you can do this, but every 3 months or in the whole year, they checked by psychiatrist. Okay. Yeah, that is I think this is a fact. So I want to share this information.
Thank you very much for
one more.
yes.
Yeah. and I think I'm thankful because very good company of Denmark developed new antidepressant for 20 years. Thank you.
But I guess some of the older antidepressants were quite difficult with side effects and more dangerous.
I think the reason is that your experience is a high rate of the suicide rate, so they invest. We make the proper drug to treat the antidepressant, right? Yeah.
I have one more question.
Yes,
time,
please.
okay?
Yes, please.
One more question. I think for you, Dr. Pike, I think you talked about the proper test and evaluation to identify if people have depressions or not and so on. Huh? Am I right? You mentioned that in your presentation. And I think in Denmark, we, at least I was not aware until, we had our own kids. I should maybe also present in the corner is my wife sitting over there. She's a health nurse and also master of public health. And in Denmark, we have a system that, when you get a child, you have a health nurse, like my wife, visiting you 6 or 8 times, Ingrid, I'm not sure how many, over a couple of years. She can elaborate afterwards. And after 2 months, you have a special test for the parents to see if mother has depression or even father. So it's a scoring. Maybe you should explain yourself, but kind of a scoring system where you actually can see. And that way, I think it's an early way to find out. But maybe you can explain better, Ingrid.
We started the system actually 10 years ago, and it's done all over in Denmark. So this means that all the parents get the offer, so it's voluntary, to get a screening when the baby is 2 months old, or even when we discover some problems before we can do it for or later. There are 2 different screening systems. One is called EPDS, and it contains 10 questions around your mental state. 7 days after when we came to visit, or 4 weeks. And the other one is Gotland. And I think you know the EPDS because this is made for depression generally, but it's modified for parents because postnatal depression is a bit different as normal depressions. And there we can detect some problems, and if we find some, we can refer to the GP. And in the community, we also have psychologists who can treat the beginnings. There are 5 meetings, and if this psychologist finds some problems, they can refer again. Or we also, in our system with the nurses, we have groups where we can work with the parents. And there is one doctor at the Riis Hospital, Sven Ove Madsen. He works very much with fathers because we also have detected that there are many fathers who have also problems with coping to getting fathers. So I think we can detect quite early. And I was actually wondering if this would be a possibility, because Dr. Pike, you mentioned that there are age groups where you can see the risk for depression. You mentioned military people and younger and elderly. And I was thinking if it would be possible to send screening system out, like we do screenings for breast cancer or rectum cancer, so we get a letter. If you have a certain age, for example, you are a woman in Denmark about 50, then every 3rd year you get a test, an offer to come in for a mammography, for screening. And I think maybe if you could see from your statistic, we can see the high incidence or risk for suicide. You could do this by sending screening tests. And then you can get it back to the doctor, to the GP, and then find out is there a risk, and then you can find them. So this would be preventive and a very, very early inventive. Mm-hmm. It was just a thought of me. Thank you.
Any further comments or questions? If not, I think we will move to a break. We are a little bit ahead of schedule, so we will use that for half an hour break, and we will reconvene again at 5:40 Korean time, which should be 10:40 in Denmark, for the second half of this seminar. Thank you very much. Welcome back to the primary healthcare seminar on mental health. We will now turn to hear the patient perspective from both Denmark and from Korea. Our first intervention is from Mr. Mogens Lønborg, who is the president of the Danish Depression Association. Please, President Lønborg, the floor is yours.
Thank you very much. Can you hear me?
Yes.
Okay. Thank you for inviting me. My name is Mogens Lønborg, and I have been elected president of the Danish Depression Association in May this year. Before I, just a minute, I have to change. I can't change. Can I change the slide? Sorry. I really have. Why do I? I think there. Yeah, okay. Yes. Before I get into the details, allow me to give few facts about depression and affective disorders in Denmark. Overall, we assess that between 150,000 and 250,000 people in Denmark are affected by depression each year. In percent, it means 2.5 up to 4.3% of the population. This also means that about 70 to 18%, or about 1 in 6, will experience some sort of depression during their lifetime. And about 70 affected are women. But there are strong indicators that there may be many undiagnosed men. This is due, amongst other reasons, to the fact that men tend to occupy statistics in other ways. For example, men dominate statistics of substance abuse. The majority of people with depression that we meet in our association are people from the age of 30 to 60. But the relative highest prevalence is among young people aged 16 to 24. We have been invited to talk about the patient's journey in the health sector, seen from the citizen's perspective. It is a point in its own right that most people don't see themselves as patients just because they have a depression. For many people, it is a barrier to admit that they have depression or a mental disorder. This implies that a lot of people do not go to their general practitioners in the first place. We do not have official figures for the exact number, but most sources estimate that less than 50% of those suffering from mental health problems actually go to the doctor. About 90% of those diagnosed with unipolar depression are treated by their GP. If you go to the doctor, not all get a diagnosis, and not all get the correct diagnosis, and not all get or want the treatment available. This means that in reality, it is only a minority of the citizens suffering from depression and mental health problems that give the correct treatment from beginning. Once you are with your GP, the doctor will assess the patient by using the WHO MDI test. Depending on the level of the depression, mild, moderate, or severe, the citizen is offered a combination of treatments that you will see on the slide: medicine, antidepressants, cognitive therapy by psychologists, or if severe and the GP believes there is a need for specialist treatment with a combination of medication and counseling, the patient can be referred to a psychiatrist. If very severe and the patient is, for example, psychotic or suicidal, he or she is referred to acute mental hospitalization and treatment. What we observe is that when you are hit by depression, your options for the treatment are good, but they are better on paper than in reality. A number of factors point to this. There is a very long waiting list for therapy by psychologists spanning from 8 weeks up to a year. 2, there is an even longer waiting list for psychiatrists. This causes indirect negative effects because some GPs do tricks in the book to bypass the system and help the patient. For example, they refer moderately ill patients to the acute emergency hospital treatment, as they must see a psychiatrist before they can get a medication treatment plan. And this may, of course, add to the pressure of the emergency capacity at mental hospitals. About 1/3 do not get a positive effect of combined treatment. This causes frustration and leads to a worsened social and psychiatric condition. A strong feature is that young people below 8 to 26 can now get therapy treatment for free. This has provided preventive support to thousands of young people, which is essential for recovery and long-term mental health. However, this rule also causes inequality in health. If, for example, you are 27 or more, further, you still have to deal with a waiting list, even if you are young. A weak point always mentioned by patients is that they have to navigate very complex bureaucratic procedures and follow up themselves. They must link with their GP, the employment, the office, the social services, the insurance company, the psychologist, the psychiatrist. This is too difficult for people suffering from depression. And even without, it is difficult. A major challenge is linked to the ability of the Danish society to reintegrate into the labor market people who have suffered from depression and mental illness. Very often, the citizen is suffering from a reduced work capacity, especially in the early phases of the recovery. There are very good and supportive measures for the minority who have been most ill. They can get light-duty jobs, and mechanisms are in place so that they can start at a limited number of working hours per week and slowly increase their work capacity at pace with their recovery. However, for the far majority, this is not a solution, as they are not offered this reintroduction package. Many of those who have suffered from one or several episodes of depression find that they cannot live up to the work expectations that are in the job functions, which originally contributed to make them sick. There is a need to reform the health sector in combination with the labor market sector in order to provide more jobs with a higher degree of individual customization and flexibility. This will better match the need of people having mental health issues and allow them to slowly regain their position. Thus, for some advice seen from our NGO. First, the health sector must have fast, and flexible access to treatment to stop the disorder developing. 2. Support must be given to patients follow-up in the form of process coordinators. 3. The labor market must be equipped with flexible job opportunities for ex-patients. And 4. Large-scale public campaigns are needed to shed light on mental health to help understanding and reduce stigma. This was my words. Thank you for listening.
Thank you so very much, Mr. Lundborg, for providing us with those perspectives from Denmark. After we have now heard from a Danish patient organization, we will turn to the president of Mental Health Korea, Mr. Choi. Mr. Choi will present together with a peer specialist, Ms. Lee. They will be talking about the climate for mental health of the youth in Korea.
Okay. Hello. Hi. Ambassador Jensen, I have a quick confession to make. I decided to take Lexapro from Lundbeck instead of a product from American company. So I thought this would be a nice move for me to be diplomatically correct to be here. So just to let you know. Okay. So youth mental health climate and crisis. Thank you. That's my picture a couple of years ago. Maybe look younger. So I'm the founder of Mental Health Korea in Korea. In 2018, we launched a multi-year project to reduce the stigma and to normalize the conversation about mental health. So we are the most innovative consumer movement NGO here in Korea. So we have 4 sectors. Peer school, we actually educate young peers to become a leader. And peer insight is consumer report. We rate doctors and service providers to give out correct information to public. Peer support, we are actually connected 24/7 to give out support from teens and young adults who experienced before. And also social prescribing. And we have one of the largest social support group, online and offline, especially with people, families of severe mental illness, such as schizophrenia. We use the word of consumer instead of the word of patient because patient in Korean has so much stigma attached to it, especially sometimes it's weaponized by people. I think the word of consumer, word of patient should just only use under the care of professionals, mental health professionals. So there is an oppression occurs when dialogue becomes monologue. So we are developing empowered and smart consumer instead of just self-stigmatizing. Like nowadays, there's a big word coming. Everybody is using the word gaslighting, right? When people use it toward themselves, it's a kind of form of self-gaslighting or self-stigma. So we call it peer specialists, those educated people. So kids are, like teenagers are telling me that they are victims of social injustice here in Korea. They're victims of incest, sexual crime, bullying, LGBTQ+A issues, self-harming, and suicide issues. So we have this solution for this changing the mental health climate. First, empower youth leadership. And second, we hear the voice. That means we validate their feelings as a leaders. Third, success story. because oftentimes teens who are suffering from mental health issues or with the suicidal thoughts, they're often looking for like help or to be better. They want to be better, but it's hard time for them to find the other peers just at the age exactly same as them. So our peer specialists as a role model, it is really important for them to change mental health climate. So by giving them hope and confidence for them to get better, that's our solution to change mental health climate in Korea. So first, active peer specialists became a role model here in Korea. And also, first ever teenagers spoke major seminars and conferences. Thank you for you guys, like doctors. And also, they were featured many outlets of media, such as CNN, KBS, SBS, and major publications as well. So they used their story to reach out and change the society and then reduce the stigma and then enhance the early intervention. So they use their story on social media to create social impact so far. That's very brave. I call them as a surviving hero. So, dear Ambassador Jansen, do you remember those people, peer specialists you invited a couple of years ago? You know what? They become the authors of new, just came out. The book, okay, it's right here. It is the first ever book published by the teens with lived experience. So the title is Our Wounds Are Honest. So I will give it to you after I finish. Please read the book and please spread the word because teens, they want to express their feeling in order to help others. So please, I want to really asking you to spread word and in order to reach the message written by those teens. So I would like to finish my speech. This important word, maybe you guys heard about it. Nothing about us without us. So it is really important to include those who already suffered. It's one of them. And it is time for action. That is today. Thank you. Thank you. Thank you. Now, I will introduce one of our peer specialists. Let's hear her voice. Okay. Ju Eun-lee.
Hi, I am a peer specialist, a suicide survivor, and a person who used to cut my skin for 6 years. I'm not self-harmer now, but I'm still taking antidepressants. It is Lexapro. When I was 15, I tried to end my life, but I was failed. Don't ask me how, I don't want to remember. So I had to be hospitalized. I was locked up in the hospital for months. And you know, the hospital I was in was known as nice facilities. Actually, it was not bad. I could relax in a comfortable environment when I was in the hospital. But after I came back home from hospital, the only thing I could do was just crying because I could not get used to my ordinary life. My home was just a nightmare. because I had to face with my hopeless life in my messy room. I could remember all things about my painful past when I was sitting in my room. So I cried until I was drained. But I had to go back to school soon after, and I noticed other students are well adapted to the new environment easily. All of the students were studying very hard except me. I knew that they had prepared and studied very well to do better at school. Yeah, maybe I could be one of them if I didn't try to kill myself. I knew that I was behind at school when I spent a month there. Teachers actually told me that they don't have any hope for me because I was mentally ill and they thought that I would not be normal again. Yes, I was a completely mental patient to them. I thought my future would be just miserable because they told me so. I wanted to drop out of school and kill myself again because of them. But I didn't do that. My friends were studying hard when I was suffering and locked up in a hospital. And I hate that I was behind academically. I knew that more I was in hospital, I was behind of school and harder for me to adjust in school. I sometimes cut my skin when everything was too hard for me. Then people told me, "Your illness is really bad," and isolated me again. It was really painful for me to stay in school, but I didn't quit there. People wondered how I could stay at school after hospitalization. School was a very terrible place for me, but I was also afraid of being isolated from the society. It was really painful. Now, I graduated high school and start to find ways that can help others who are suffering from mental struggles. I know there are so many painful teenagers because of school, but they cannot ask for help anywhere. So I became a peer specialist to help teenagers just like me. Some people were surprised by me and asked me questions. "You can help others? You're a patient. You're still sick." Yeah, I know. I'm still suffering from depression, but that's okay. I'm still in pain now, but I believe I'll be okay one day. I can manage my depression outside of a mental hospital. I will live with other people. You can call me a mental patient, but I know I can do better. I thought of suicide every day since I was 8 years old until now. I could not quit my life because of my school and homework. Funny, right? Well, I am a Korean student. Being a student and caring for my grades helped me to not end my life. Because I live day by day. I haven't killed myself because I cared about my grades. It's so ironic, but that made a sense to me and kept me alive. I will survive. Thank you for listening to my story.
Thank you so very, very much, President Choi and Ms. Lee. Thank you, especially Ms. Lee, for your courage. It really takes someone to be very brave to speak to us today and to share your personal story. Thank you. After hearing these perspectives, I will now say peer specialist perspectives from both countries. We will turn to presentations on how to fight stigma in both Denmark and Korea. Our first presentation on fighting stigma is by Ms. Anja Wittelsby, who is special advisor at One of Us, the Danish National Anti-Stigma Campaign. Please, Ms. Wittelsby, the floor is yours.
Thank you. 1 second, I'm trying to share my screen. It doesn't. I'm having trouble sharing my screen. Can anybody help me? I sent my presentation to you.
Assistance is coming. Assistance is on the way, I think. We can see
Yes.
your screen now.
Thank you. Perfect. Thank you. Thank you for the presentation, and thank you for inviting me today. My name is Anja Kar-Vedelsby, and I am the program manager of One of Us, which is the Danish anti-stigma program. Please change slide. Will you change the slide, please? Thank you. Go back once, please. Thank you. I only have 10 minutes, and I could talk for hours about One of Us, but I will today share with you briefly some facts about One of Us and the methods that work and which methods that don't work when doing anti-stigma work, and then give you a quick highlight from each of the 5 target areas of One of Us. Switch, please. So the vision of One of Us is to create a better life for all by promoting inclusion and combating discrimination related to mental illness. The keywords here are inclusion and discrimination. Inclusion, because the risk of exclusion is so big when you have a mental illness, especially when it starts early in life, which a lot of mental illness does, risking exclusion from the educational system and then the labor market, but also social life and many other areas. And we use the word discrimination because we refer to the UN Disability Act, prohibiting discrimination based on mental illness as well. Switch, please. So One of Us started in 2011. We've been going on for a little more than 10 years. And for the first 10 years, we were a partnership consisting of 7 large private and public organizations working within the field. And since August 1st of this year, we moved in and became an integrated part of the Danish Health Authority. And for now, we have funding for the next 4 years, but the intention is that it will be a permanent program within the Danish Health Authority. We have interventions at both the national, regional, and local level. I am located at the national level. And our mandate is to focus on knowledge, attitudes, and behavior related to anti-stigma. We do not have a mandate for criticizing structure and services and financing services for people with mental illness, because the partners behind One of Us disagree in many different ways regarding this, but everyone's agreed the whole time that it has to get easier to live with a mental illness. Switch, please. Our mission is to increase the knowledge of life with mental illness, not increase knowledge of mental illness diagnosis and symptoms in itself, but living with a mental illness. What is that like? We also work to reduce the distance that leads to stigma and prejudice and exclusion, and increase the comprehension about mental illness in schools and workplaces and wherever you encounter mental illness, because that's where everyday life takes place. We have 5 different target areas. One is service users and relative, that is people with lived experience of mental illness and relatives. It's professionals in the health and social sectors. It's the labor market, young people, and the public and the media. Switch, please. So we have everything is in Danish. I apologize for our Korean participants today, but we do have a small subsite to our website, which is in English and where some of our materials have been translated. So I would encourage everyone to go and look at that. You can find it by saying one-of-us.nu. But we also have a very active Facebook site with a really warm and inclusive community. And we have our One of Us panel. It's an online survey panel of about 1,000 people with lived experience of mental illness who have agreed to answer our questionnaires, which we send out every now and then, measuring many different things. But one of the things that this panel is very useful for is for creating new data that we can use for press stories. making journalists more susceptible to our stories because we get to offer them exclusive data. Switch, please. So, there are at least 3 important reasons to work with anti-stigma programs. One is one that we all know and see in the media, the sensational and negative portrayal of mental illness in the media, with headlines like "mentally ill commit more murders," highlighting crime and dangerousness. We also know that mental illness is a public health challenge. More and more people are struggling with mental health problems, and thereby making more and more people at risk of being affected by stigma. And thirdly, we still need to spread the message of recovery. It's been over 20 years now that we've had solid documentation that recovery from mental illness is a real possibility. But we still need to challenge the story of chronicity, which is being shared in many, many different areas, including in the mental health services sometimes. Fortunately, we do see more progressive tones as well, but we still encounter that story of chronicity saying once mentally ill, always mentally ill. And that needs to be challenged. Change, please. So another reason for challenging stigma is the very serious consequences of stigma and discrimination. I already mentioned the major risk of exclusion from all areas of life, but there's also a very reduced life expectancy and life quality. We know from Danish data that people with severe mental illness risk a 15 to 20 years reduced life expectancy. And we also know from our own surveys that there's a risk of somatic symptoms being neglected or downplayed in healthcare if you also have a mental illness. And then there's the very big risk of self-stigma. I heard the previous speaker mention this as well. Self-stigma being the process where one internalizes the prejudice that one encounters in society and believe that to be true about oneself. And that poses a major barrier. And a person risks limiting oneself, losing hope, having a sense of worthlessness, failure, and low self-esteem. And this is very serious. From a major discrimination survey that we conducted in 2015 with more than 1,200 respondents, 9 out of 10 respondents had at least one symptom of self-stigma. So this is very widespread, and it's often something that people are not aware of consciously happening. Switch, please. So when doing anti-stigma work, it's of course very important to know what works, but it's equally as important to know what doesn't work, because what doesn't work risks perpetuating stigma. So traditional communication about illnesses and symptoms, if you only do that, there's a risk of pseudo-diagnosing and increasing stigma. Also, something that's done with the best of intentions, and we see that in Denmark as well, is simplifying problems and challenges by, for example, comparing mental illness to a broken leg or diabetes. But that does not work. It leaves out the fact that the self-perception and relations are affected when one has a mental illness, and it is within those relations that uncertainty and distance can occur. So it is not the same. And one more thing that does not work is moralizing or scolding people for being stigmatizing, because it creates distance and resistance. Switch, please. So what does work is to facilitate identification and empathy, to stimulate reflection, which again can lead to attitude and behavior change. And this is done by what research calls social contact. That is meeting people and having an open dialogue with people with lived experience of mental illness, and the dialogue about mental illness. And on the right-hand side of this slide, you see Kip, who is an ambassador in One of Us, and who is he's practicing social contact in this photo. He's sharing his lived experience of mental illness at Folkemøde, which is like a democratic festival in Denmark. And first he shares his story, and then he is available for debate and questions after. And in One of Us, we call the volunteers ambassadors. And something else that works is to challenge myths with facts. And I'm not sure the third point translates very well, and I apologize for that. But intrude with statements without being intrusive, meaning we try to shake people up a little bit. It's okay if it hurts a little when being challenged about stigma. And just going back to social contact, this can be done in many different ways. It can be done face-to-face, like you see Kim doing in the photo, but it can also be done via film, radio, theater, in the media in general, social media, wherever there's opportunity to share lived experience, and especially when having a dialogue about this. Switch, please. So now I'll give you a quick highlight from each of the 5 target areas. Switch, please. So for the target area service users and relatives, we have a self-stigma program. It's originally from an American and Israeli material called Narrative Enhancement and Cognitive Therapy, which we made a translation and an adapted version, which the Danish translates into personal story and self-stigma. It's a 20-session manualized group intervention, which consists of psychoeducation, cognitive restructuring, and storytelling exercises. Yeah, I could talk for a long time about this, but I'll switch, please. For the next target area, professionals in the health and social services, we have the Dialogue Kickstarter, targeted mental health professionals. And the objective is to create awareness of communication, to motivate staff to a dialogue on respectful language and acknowledging culture and social conventions, and to have the staff work in a more goal-directed manner to promote anti-stigma. And the toolkit, the main ingredient here is film with ambassadors. Ambassadors sharing different experience from being within mental health services. Switch, please. For the target area, the labor market, we have developed dialogue cards for professionals in job centers. And I already mentioned that mental illness increases the risk of exclusion. So the job centers are working with people who are on sick leave or who are not in the labor market, perhaps due to mental illness, or people who have mental illness as part of their experience. And this drawing is one of the dialogue cards illustrating the very narrow access to the labor market. And sometimes people don't fit into that. So as I just heard one of the previous speakers talk about, we need a more flexible labor market that leaves room for maybe fewer work hours or just different conditions than maybe some other employees. Switch, please. For the target area, young people, we have an interactive website called Break the Silence, which the main ingredient here are a series of interactive films. And everything is wrapped up in guidelines for teachers about film analysis, media production, and debate. So it's very easy to include in the curriculum. Switch, please. So for the last target area, the public and the media, we have, for example, the 1 in 5 campaign indicated that 1 in 5 people have a mental illness themselves within a year. And the material contains facts, advice, and personal stories. And for the media, we have guidelines called Think Before You Type, Tænk før du tester in Danish, giving advice on how to cover mental illness in a responsible manner, which is also not stigmatizing. Switch, please. And that was it from me. Thank you, and I'll be happy to answer any questions you may have.
Thank you very much. Thank you very much, Ms. Whittleby, for presenting how you are working on anti-stigma. We will now turn to our last presentation by Mr. Ko, who is Executive Director of the NGO Good With Us. He will be presenting the music video Treasure and talking about how the K-pop industry can contribute to suicide prevention. Please, Executive Director Ko.
Hi, music video on suicide prevention created by K-pop, producer youth creator. Presentation. Yeah, excuse me. Yeah. Yeah, culture prevention naming is mind hug. Continue difficulty due to COVID-19. Young creator and small business owner to each other psychological, emotional consolation. Level 1, MG generation creator selection. Level 2, empowerment program support. Level 3, mentoring. Level 4, video contents, production, transmission, on offline activity. Young creator education activity support, small business owner. Youth creator education, suicide prevention education, well-dying, suicide gatekeeping, meeting with the survivor of suicide. Yeah. Composition training, suicide music, contents, and studio recording. Anti-stigma movement is mind hug, suicide, survival of suicide, youth, small business, middle ages, prevention and consolation. Mind hug challenge, send your mind. sendyourmind.org. Yeah. Mobile text sending system on offline mind hug. Yeah. Participated in K-pop artist Purple Kiss and youth creator. Yeah. A song the composed the youth composer Jenaeun. Yeah. Produce Yoon Youngjun, K-pop producer. Yeah. Meaning, yeah.
Hi, I'm Jenaeun, a songwriter of this track, Treasure. It's my honor to present this song to you. When I was asked to write a song about mental health, I wanted to talk about self-esteem and how to trust in yourself because it is one of the most significant topics in this difficult time, I think. I used to think that I could love myself and love my life once I achieve everything and gain recognition for that. However, it was not true. In my experience, I could be able to love and trust in myself only after all the hardship and trouble and seeing myself bounce back from it, like the most precious treasure is buried in the abyss. I wanted to share this story through this song Treasure, and I hope you enjoy it too. Thank you.
Yeah. Yeah.
So before we actually watch the Treasure video, I want you all to have a look at the slides because the lyrics will all be in Korean, but it's been translated as you can see, and you also have printouts for everybody because when we go to the music video itself, you won't be able to see the lyrics on screen.
Next, yeah.
So I'll just, as recommended, read it out. Did I build the castle on sand? Shakes even with a little tide. Although I've always believed that I was safe with this fort, this mirror lacked genuineness. This heart missed something. Never stopped, but somehow got lost. All scar has been concealed. What I've believed, what I've protected, seeing them shattering into dust, I sank. But it turned out where I was looking for is here. Beyond the sticky swamp and deep water, somewhere in between hate and wish for my life, fell into the abyss of myself, then I found my treasure. Beyond the abandoned forest and harsh maze, somewhere between pain and faith, took off from the most fragile road, I found I am treasure. Treasure, treasure, I am treasure.
Yeah, let's sing together.
끈적한 늪과 깊은 해저를 지나 간절한 승과 미움 사이 어딘가 가장 밑바닥에서 찾아 열어볼 나의 treasure. 엉뚱한 길을 찾아 헤맨다. 사람들은 분명 여기라는데 난 높은 구도에 숨이 막혀와. 다들 재킷발을 꽂기 바쁜데 저 눈들 속엔 진짜가 없어. 그 마음 속엔 무언가 없어. 여기 우리는 길을 잃었어. 오랜 지도는 힘을 잃었어. 믿어왔던 것, 지켜왔던 것, 가루처럼 휘날리는 걸 보다 끝내 가라앉은 곳, 근데 내가 찾던 곳 어쩌면 여긴 것 같아. 끈적한 늪과 깊은 해저를 지나 간절한 승과 미움 사이 어딘가 가장 밑바닥에서 찾아 열어볼 나의 treasure. treasure, treasure, 나의 treasure, treasure. treasure, treasure, 나의 treasure, treasure, 나의 treasure, treasure. treasure, treasure, 나의 난 모래 위에 성을 지었나. 작은 세파에도 위태로운 게 이 요새 위에서는 언제나 난 안전하다 생각했는데 이 거울 속엔 진짜가 없어. 내 마음 속엔 무언가 없어. 쉰 적 없는데 길을 잃었어. 오랜 상처는 덮여 있었어. 믿어왔던 것, 지켜왔던 것, 가루처럼 휘날리는 걸 보다 끝내 가라앉은 곳, 진짜 나를 만날 곳 어쩌면 여긴 것 같아. 끈적한 늪과 깊은 해저를 지나 간절한 승과 미움 사이 어딘가 가장 밑바닥에서 찾아 열어볼 나의 treasure. 버려진 숲과 거친 미로를 지나 벅찬 아픔과 믿음 사이 어딘가 가장 나아가 그래서 나 올라온 나는 treasure. treasure, treasure, 나는 treasure, treasure. treasure, treasure, 나는 treasure, treasure, 나는 treasure, treasure. treasure, treasure, 나는
Yeah, thank you.
Thank you very much, Executive Director Ko. We will now turn to our second round of discussion, and this time focusing on stigma and access to help. First, let me start by asking Ms. Wedelsby. I believe that we have both Ms. Wedelsby and also President Lønborg with us online for this discussion. Ms. Wedelsby, I would like to ask you, how can we overcome the stigma related to mental health? I know that you have spoken to a number of initiatives from the One of Us campaign, but since we're still not there yet, what other sort of initiatives do you see are needed, perhaps from different parts of society? If you could please share your thoughts on that.
Yeah, I think we should share experience to as much as we can, and then use that experience within the different sectors, the major sectors of society where we need to reduce stigma. For example, having mental health problems or mental health on the curriculum for school kids. We could also make rules for the labor market to include people to a higher degree within the labor market. And within the health and mental health services, it should be also obligatory to deal with anti-stigma. So I think we need to make it a formal part of the major life areas, you can say, where you encounter mental illness.
Thank you very much, Ms. Wedelsby. And my second question goes both to President Lønborg, who's with us online, as well as President Choi and Ms. Lee of Mental Health Korea. I would like to ask you from the peer specialist perspective, from the consumer perspective, are there any barriers to seeking help for you? Perhaps I don't know if President Choi, would you like to go first in sharing some reflections?
Like barriers for the consumers, or
yes.
I don't know. It's been. I think stigma is a part of our culture. It's been like here like a long time. I don't think it's gonna be like gone soon. So my focus is just try to change mental health climate. It's easier for us just to change it by naming the right one. Actually, mental health climate meaning that is using right terminology, but not feeling bad about it. Just like maybe consumer is a better word because it's empowering kind of thing. Also other leadership. So like the people from Denmark was talking about, by the creating the legislation and then forcing the anti-discrimination against mental health or reduce the stigma or prejudice, it kind of help us to kind of open or seeking kind of help. I think that's available. Also, I think in order to change mental health climate, I think we need to make more role models because we have to show them we are exist and it can be dealt with the condition and live well with the right amount of treatment and help of others. And this is crucial that we do not want to be them to be really isolated and suffer by themselves because it is social justice. It's our problem, not individuals' fault. So this is really important by educating young people, starting young age. I think that's how I create this mental health career, and I'm just focusing on changing the mental health climate. So I'm not sure if I answered your question. That's my thought on prejudice and stigma against mental health.
Yes, you definitely did. And I would also like to ask President Lønborg, from your perspective in Denmark, what are the barriers in Denmark? What are the challenges for receiving help and treatment?
It's a big question, and first of all, I have to tell you that I am not specialist in this subject. I'm a very new elected president of the organization, and I have no personal experiences in that subject. But I think that it has to do with also the problem of stigma, because the mental illness is still seen as something you are not aware of. What's that? We have not information about it, and therefore you also have you are concerned about what are the side effects of a treatment. And then I also think that it's for many people it's not a convenient to be offer for some treatment in this subject. As the Korea case showed, they call it not patients, they call it consumers, and I think it has to do with this also, that we are a little anxious about being in this role as a patient who need treatment. So I think we have to overcome these barriers. Many things have to be done, but it's very important that we are showing with role models that it is not so unnormal to have some mental illness, as many people, I think, have the impression it is. So but it's of course a difficult question.
It is, but it's some very good points you're providing us with, President Lønborg. Thank you for that. I would now open the floor for any comments, questions, and of course you're also very welcome to pose any comments and questions from the Danish side online. Please let us know if you would like to do that, Ms. Wittelsby and President Lønborg. Yes, please.
Hi. Good to see you, Anja Kjær. I had experience to visit one of us 2 years ago, and hi. To hear from her. That time I was very touching. Very many patients and caregivers uncover their face and talk about their experience of severe mental illness. So it was very impressive. And she told me the principle of one of us use the humor, just like Viking cartoon. yeah. And do not criticize anyone because many people until now have some stigma. So to deal with anti-stigma movement, they don't criticize anyone, but use humor. Your word was very impressive for me. Thank you.
Thank you very much, Dr. Pike. And perhaps you want to comment on that, Ms. Wittelsby?
Yes, thank you. And hi, nice to see you again. Well, we have, I think I should mention that we have about a little less than 200 people with lived experience who are volunteers in One of Us as ambassadors and who share their personal experience of mental illness. And in order to do so, it's crucial that the volunteers have sufficient training, communication training, where they learn to share their experience, targeted different audiences. Because everyone shouldn't hear your entire life story from beginning to end. So it's really important it's always targeted. For example, if you're speaking to mental health professionals in a closed ward, you could share experience from being yourself a patient in a closed ward. And when speaking to school children, it would be obvious that you could share your experience from being in school yourself. So it's really important that all the volunteers or ambassadors are in a good place in their life where they are able to do this, to share this experience and also feel sufficiently supported by the program, by one of us, and that they feel sufficiently prepared every time they have to go speak to a new audience or one of us activity. So I just thought I should mention that the volunteers are absolutely essential for anti-stigma work because they are the ones practicing social contact, but also they need support and training. Yeah. So, and yes, we love using humor because it's such a serious, potentially very serious subject to speak about mental illness. But I think I should also say that as a general rule, people don't stigmatize because they're evil. So we shouldn't scold them. We should try and make them aware of what's going on and make them reflect about what they do themselves. So because usually stigma is founded in misunderstandings or a lack of knowledge or insecurity. And we want to make people aware to act in a non-stigmatizing manner by being aware of this.
I have,
yes.
I want to add to what Anja said, that I think it's also very important that famous people who have some illness problems are prepared to tell it. For a few days ago, I was watching the television in Denmark. A very famous Danish musician is called Mads Langer. He has some mental illness. I didn't know that. Many people probably didn't know that. But he was very honest about it, telling what was his problem. And he's still going. He's a very famous musician. And he said that at the moment when he was on the television, he had some problems also. And still he could function and he could do everything. I think it's important to show that people still with mental illness problems are able to function, able to be normal. It's very important.
Thank you very much, and that's exactly the work that Good With Us is doing. So that's good to hear that that's also happening in Denmark. President-elect O has a comment.
Yes, I totally agree with your ideation and your comment, especially President Choi. I believe that most of stigma is from inaccurate knowledge and not enough information. Because recently, in the past, we have no enough information about mental illnesses, like depression or schizophrenia. However, recently, many scientific studies showed that there is a kind of a brain disorder. For example, recently for the elderly depressed patient with brain MRI, you can find some special changing that showed that the hyperactivity of brain, especially in the frontal area. So with proper, accurate information, we can reduce the stigma. And also the other thing is the role model about famous people. Usually, ordinary people, they can remember the bad things. The famous movie star commit suicide or other things. However, in the world, there are very famous people like Abraham Lincoln in the United States president. He had depression. The Churchill, England prime minister, he had maybe bipolar disorder or depression. Or other many artists. I remember the Pablo Casals. He was a cellist, the most famous cellist in the world. He has social anxiety problems. So we have to remember the very famous and very successful people, even though they have some mental illnesses. So we have proper, accurate information. We have to spread the accurate knowledge, and we have to spread the scientific fact, so we can reduce stigma about mental illness.
Thank you very much for sharing, President-elect Oh. And I think Dr. Huang has also an intervention.
So I have a question to Anza, and you mentioned that one of us working for the labor market. I think it's the same in Korea. So I was working for the vocational rehabilitation for the chronic mentally ill patients, and finally, if after finishing the training course, it's very hard to getting a job in the community. So somebody said that connecting the mental health area and the labor market as the just like a bridge over troubled water. So it's very difficult here to hiring the ex-patient in the company or the labor market. How about the condition in Denmark? Could you explain more about the labor market in Denmark?
Ms. Wittelsby, please.
Yes, thank you. I think the labor market probably is as closed for people with mental illness in Denmark as it is in Korea. We definitely have major barriers for employment for people with mental illness. But one very positive, a project with very positive outcomes that induces hope right now is the IPS, Individual Placement and Support. I don't know if you're familiar with that, but it is for people who have recently been discharged for a mental illness and who have very close support, and very early on they start working, and it has to be a job that they themselves find meaningful. It can't just be any job where they have to dig holes or whatever you may think is a good idea. It has to be something that that person is qualified for and motivated for. And then they have very close support and very close dialogue and between all actors in the rehabilitation program. So there's a dialogue with the employer and about also colleagues, how to have how to share with colleagues what problems you may have for with having a job if you do have some, and also a very close connection to your treatment. So everything is very well coordinated, and the person with the mental illness is actually at the center. In Denmark, people always say the person at the center, but very few people actually practice that. So this is a very promising project with really good results, and I would encourage you to look at that. And that is individual placement and support. But another thing I wanted just to comment on is the suggestion to use famous people for sharing their lived experience, and I think that is a good idea. We don't use it in One of Us. We did it a little bit in the beginning because famous people can be good for drawing attention to the area, and that is very useful. But for changing attitudes and behavior related to mental illness, you need people that you can identify with. Someone where you think, oh, that's just like me. This is a mother just like me, or this is whatever you identify with. So the famous people can draw attention, and then it's the ambassadors, the people with lived experience who have training in sharing their experience. They actually change the attitudes and behavior. And then one final comment for the speaker before, or the commenter before, about giving correct information, and I think that's very correct, yeah. Because myths and misunderstandings and prejudice are a major part of stigma. But you always have to have the personal experience as part of that. I already talked about that. But when using, I know you can locate part of the brain, you can locate changes in the brain, But this is a contended area because we don't know, was it there before or was it changed because of the mental illness? And in an anti-stigma perspective, the brain argument works counterproductively because if the argument is mental illness is a brain disease, the audience will have more empathy with the person with the brain disease, but they will want more social distance. So this argument actually increases stigma, even though it seems very logical, but it makes it so that people don't want to be close to the people with the brain diseases. They don't want to have them as neighbors or work in the same workplace or wherever you meet other people. Yeah, that's it for me.
Thank you very much, Ms. Widdelsby.
Thank you. I agree with your opinion. However, I think to the all patients with physical illness, even though for the patient with the physical illness, some people they can have stigma or prejudice. Yeah? For the diabetes patient or hypertension patient or other cancer patients, even though. So everybody can have some stigma about that. For example, ordinary people, other people, they used to think they have an illness, so they can work harder or other stigma. I mean, but the exact thing is we have to know the accurate knowledge about the disease. So we have to sometimes we have to accept our situation, our physical and mental state. Even though the normal people, they can have sometimes they can have depressed mood or anxious state. They can have. So at the time we have to give accurate state information, and with that we can overcome. So I mean, why I'm introducing the brain imaging, with proper treatment, the brain activity can change. So after that, several months later, we can after we recheck the brain imaging, the sign or symptoms can disappear. So we can give some hope, and we can reduce the stigma. So I mentioned about that. Yeah.
Thank you very much. I think we would have time for one final comment or question. Yes?
Sorry, I mentioned so much. But finally, I'd like to mention about the peer specialist. I think peer specialist can be the game changer to prevent adolescent suicide, because peer is the most influential people to other peer group. So your activity is so treacherous and very important thing. So we have to encourage their activities, and we have to help them to spread their activities. Yeah.
Thank you very much, President O, for that final comment. And I think that quite clearly reflects what Ms. Widdelsby was also talking to in terms of how important it is to identify. So thank you very much to you for that. And I would like to thank all presenters here and all interventions, and to everyone who engaged and listened into this seminar. Before the close of this seminar, I will hand over to His Excellency Einar Jensen, the Ambassador of Denmark to Korea, for his final remarks. Thank you.
Thank you very much. And thank you to all for providing support for such a successful seminar here today in my residence. I think we have learned a lot on primary healthcare, mental health in Korea and Denmark. And special thanks to all the presenters many good questions. I think that we had wonderful debate today. World Mental Health Day is just 2 days away on Sunday. And we will continue during October to have focus on mental health. So that stays with us. I think today we have touched upon many very interesting topics. We have learned about, the treatment challenges in terms of getting the treatment and access and how we do it and what might work best and so on. I think we stayed a lot with the early intervention as being something that is crucial. If we do not get to the people in need in time, we fail. We talked about access to information. How do the people that need the information actually get what they need? And how do we service them? The 24 hours hotlines we have heard about today, with somebody at the other end actually to talk to the person in need, has been some of the things I've taken away from here and, will focus on. We have also got a broad insight into the mental health care and suicide prevention in our 2 countries. And in the last session here, we talked a lot about stigma. And I'm very glad to see that we do not talk about patients, we talk about consumers. I'm also glad to see that Mental Health Care Korea have the peer specialists, like one of us in Denmark has got the ambassadors. And I truly believe that these peer specialists and ambassadors helps a lot, especially for those in need, if they can see themselves, and if they can see somebody has been in the same situation and moved ahead, managed to succeed. That will be helpful, I believe, very much. I must also say that Good With Us and the film Treasure touched my heart, in the sense that, a person that builds up self-esteem to making such a beautiful song, wonderful to see. So I can only say that we have touched many areas today, and I can only wish all of you good luck in the future. I'm glad to see that we have these organizations out there helping and meeting the consumers, lending them a hand. But now it's time to say goodbye, at least for those in Denmark. So thank you to those in Denmark participating. Thank you to everybody listening in today. We will be back with other seminars. And then I want to at least invite those of you here in the room here tonight, that we can share some food and some good time together and continue discussions. So thank you very much. 감사합니다.
Recording stopped.